Good morning. Today's clinical situation is a raised alpha-fetoprotein level on quadruple marker testing. So, a 30-year-old primigravida who had conceived spontaneously was sent to me for a second opinion. She had a raised alpha-fetoprotein level on her quadruple marker test, which was done at about 15 weeks. The risk for trisomies 21, 18, and 13 was in the range of 1 in 1000. Now, this couple, because they were told that there is an abnormality on the quadruple marker test, was in a state of emotional distress, and thoughts of terminating the pregnancy had crossed their minds. They wanted a second opinion as to how to proceed further. Naturally, the first thing that one would do in this situation is to look for reporting errors. What is the source of these errors? The most common thing is a wrongly dated report. So the date for the pregnancy should be fixed as per the CRL of a first trimester scan, preferably the NT scan. Another source of errors is if a twin pregnancy is there and it is considered as a singleton, then the levels are going to be high. The next step, or the error which can creep in, is a non-standardized lab, but that has been mitigated to a large extent in modern times. The risk of chromosomal abnormalities should be assessed. In this particular situation, the risk was low and the ultrasound markers were also normal. So that was reassuring. Should this trigger any further invasive testing? In fact, not. Alpha-fetoprotein levels in trisomies are low, and a high alpha-fetoprotein level should therefore not be a trigger for amniocentesis or any other type of invasive testing. The next consideration is, of course, to rule out anatomical abnormalities in the midline. This could be in the form of neural tube defects, right from an anencephaly to a low meningomyelocele. It could also be anterior defects of the abdominal wall, including gastroschisis. So as soon as such a report comes in, a level 2 ultrasound should be performed at 15-16 weeks and then repeated at 19 or 20 weeks. If two ultrasound reports done by experienced operators are normal and does not show any significant abnormality, the chances that a child will be born with significant neural tube defect or anatomical abnormalities is only about 1% or so. This should be emphasized in the counseling of this couple because this can affect how they make further decisions. Usually at this point, no further testing is indicated as far as finding out abnormalities in this pregnancy. But let's remember that alpha-fetoprotein level can be a marker for placental dysfunction in the future, and this pregnancy is still at risk for early onset preeclampsia, fetal growth restriction, oligohydramnios, and the perinatal mortality rate is slightly higher than other pregnancies. So if you take a baseline of 1 in 600, 1 in 700 as perinatal mortality, then in this type of a pregnancy, the risk would be about 1 in 200 or 1 in 300 or so. So you could try to reduce this risk by empirically giving low dose aspirin, arginine, or other vasodilators. But the important thing is monitoring this pregnancy with regular ultrasound and color Doppler, and as needed, obstetric interventions including a preterm delivery may be required. So an in-depth counseling and a holistic approach is what is required in this kind of a situation. Thank you for listening.